big top line result for me from ischemia is that the routine application of revascularization in patients who have at least moderate, if not severe, ischemia on functional testing does not have to go to the cath lab for revascularization, that they really can be treated with aggressive medical therapy. If their symptoms, however, don't resolve, we now know that revascularization clearly will improve quality of life by alleviation of symptoms. I think those are things that many of us believed, but belief is not the same as data, and now I think we have data to show that.
Ischemia gives a viable option to early medical therapy and also relieves us of this pressure or anxiety or even panic to rush somebody to the catheterization lab just because they have a positive stress test with large ischemia. I will say that is by far, from a cath doc standpoint, the biggest addition of this trial and the biggest way it'll probably change practice for me. And it won't actually necessarily change my practice, but it could change the practice of folks who refer to me. They might be less vulnerable to a sense of concern or anxiety about these patients and the urgency of the catheterization.
If medical therapy doesn't alleviate their symptoms, going to the cath lab, identifying the anatomic lesion, and then offering revascularization is an important step to be able to alleviate angina and improve quality of life. So I think what it really does, the ischemia trials, is it provides a base of data for us to have more informed conversations with our patients.
There are going to be some patients who are going to prefer PCI procedures for symptom relief relatively early. Maybe that is due to their job or other lifestyle considerations. There are those who would probably prefer strategies of optimal medical therapy optimization more rigorously early. And then there are those who are going to try to optimize their medical therapies and maybe be intolerant of it or have other adverse consequences, sometimes even financial, for continuing to take these pills. So being able to tailor the results of this trial to the individual patients, both clinical and lifestyle circumstances, is going to be key. And I think that's why even a trial that's as important as this is still not going to lead to an algorithmic approach to patients with stable ischemic heart disease, nor in my opinion should it. Your average doc is under the gun with 12-minute visits and does not necessarily have research coordinators talking to patients to see where they're at in terms of their medical regimens.
Remember, in ischemia, we did something very interesting, which was not routine clinical practice. People came in with symptoms, they got a stress test, they had a certain amount of ischemia, in this case, a fair bit, at least moderate, involving a significant portion of the left ventricle. And then they went to cardiac CT that was blinded to the investigator. I could absolutely see that as a possibility where we go CT angiography as a first strategy, the anatomic strategy, so to speak, as opposed to the functional piece. Part of me as a clinical cardiologist who really likes all of the information I get from stress testing says, geez, I'm not ready to just go to anatomy, because in my practice I like to know, how long did you exercise? How long did you exercise before you had symptoms? What did your blood pressure do during exercise? What did your heart rate do? Because I do tailor my medical therapy around some of those results of what I'll call the physiologic parameters or the physiologic response to exercise. So that's why I think we have to think about this a little bit more. There's a lot of information that you get out of stress testing. Maybe what it means, you know, it's a class 1 recommendation that when you're going to do stress testing, if you have a normal baseline ECG, you're supposed to have stress testing without imaging attached to it. But at least in the United States, much, if not most, of the stress testing ordered by cardiologists has imaging attached to it, either nuclear or echo. So that's going to be another interesting debate. If people like me like the physiologic parameters, maybe we should be doing that, but take away the more costly addition of the imaging that's attached to it. So there's some really important questions here for the daily practice of cardiology that I think ischemia is going to help us think about.